Very good morning to all. Uh, I first of all let me start by saying thank you to everybody to showing so much of zeal to attend our first webinar from the series of webinar forthcoming by Canadian Specialist Hospital. So I really thank everybody to join us on this Friday morning. And I thank you, our eminent speaker, Dr. Abdulameer, also, and who is my colleague at Canadian Specialist Hospital since 2009. He is there. So let me start by introducing myself. I am Dr. Rajesh Gar. I am a specialist orthopedic surgeon at Canadian Specialist Hospital, Dubai, and I'm being associated with Dubai healthcare system since 2016, and it has been a wonderful journey since last 4 years. And I have been treating all kind of orthopedic problems, including joint replacements, post injuries, spine injuries, and all kind of complex trauma. So at this Canadian Specialist Hospital, which is being JCI accredited, so your safety and care for our patient is of prime importance to us. And I can assure you that our department of orthopedics, which has most internationally trained and with their expertise, they are there to take care of all the bone and joint problems. And we have a specialized dedicated department of physiotherapy to take care of all the pre and post operative needs. So without much ado about me and my hospital, today's topic, we are going to discuss treatment of osteoporosis. So we all know osteoporosis is basically a loss of bone mass. In detail, of course, Dr. Amir will be telling you. And we should understand one thing, like I am an orthopedic surgeon, so osteoarthritis and osteoporosis, they are two different things. So I have realized most of our medical paramedical staff, they get confused between osteoarthritis and osteoporosis. And even in their clinics, we start giving calcium to osteoarthritis treatment. So osteoarthritis is problem with the cartilage, with the joints. Arth means joint, and itis means inflammation. So inflammation at the joint where the cartilage is getting destroyed is osteoarthritis, and loss of bone mass will be osteoporosis. So today we are going to discuss more about the osteoporosis and its treatment. So we all know osteoporosis across the world, around 200 million women, specifically the women, because they are more prone to osteoporosis. Why, we will come to know later. And we have more than 200 million women worldwide who suffers from osteoporosis. And as one's progress in age from 60 to 70 to 80, the ratio of these progressive osteoporosis, it keep increasing. So because of the gender, because of the racial, because of the age, there are so many factors which helps, and which is the reason for generating more osteoporosis in women. And there are certain ways to diagnose osteoporosis. We have bone mineral density, and which of course Dr. Abdulameer will be telling you more in detail. The T score, the Z score are there. And the basic treatment, like we all know that we need almost 1200 milligram of calcium plus 800 milligram international unit of vitamin D daily. Specifically, population over 40 years of age, they should be supplemented, specifically females, to avoid osteoporosis in future. And of course we have different types of calcium, different treatments are there. So there's a lot to be said about osteoporosis, and we will have all the time. So let me introduce today's speaker. He is an eminent speaker, and Dr. Abdulameer. He is a senior rheumatologist at Canadian Specialist Hospital since 2009. So good morning, Dr. Abdulameer, and really thanks a lot to be here with us and to share your views and vast experience in treating osteoporosis. And especially you have been associated with Canadian Specialist Hospital since 2009. And I should tell you, all my listeners, that Dr. Abdulameer, he is a teacher, a philosopher, and he is a guide. He has been teaching various students, undergraduate and postgraduate, at various Iraq universities, and he has authored various index journals. And in especially in today's context, he has written a beautiful article for osteoporosis, how and vitamin D deficiency, how it is related with body mass index, age, and sex, especially for the population of UAE. So we should all learn something today from our eminent speaker, Dr. Abdulameer. So let us all welcome Dr. Abdulameer to teach us all today on treatment of osteoporosis. So over to Dr. Abdulameer.
Thank you.
So we will.
Good morning, everybody. Thanks for attending this webinar. I know it's a holiday and it's difficult to attend, but thanks a lot for attending this webinar. That's because we need to discuss the very important disease which is called osteoporosis or thinning of the bone, which is very common. And you know the sequelae of osteoporosis, it leads to fracture. And every 3 seconds in the world, there's fracture due to osteoporosis. My specialty, I am a rheumatologist in Canadian Specialist Hospital. My field dealing with the joint and the bone disease. And I have more than 20 years expert in dealing with osteoporotic patients. My presentation is on osteoporosis. Osteoporosis is very common disease. It's mainly occur in the middle and old age and more common in female. But nowadays I saw many patients, also male and also in early ages. I have many patients in around 50 or 50, 51, 52. There's many patients, but it's more common in old, more than 60, more than 70. But nowadays, I think the disease it's affect young, maybe due to the lifestyle, maybe due to the food. In this half an hour, I will discuss this issue. Introduction: osteoporosis characterized by low bone mass. We see the normal bone, and here this is the normal bone, and this is the osteoporotic. We see the porous bone increase the distance between the trabeculum, which lead to thinning and fragility of the bone. With time, lead to fracture after simple trauma, like for example, cuffing or sudden bending, or sometime even simple trauma lead to fracture. And the fracture most commonly affect the vertebra, affect the hip, or affect even the ribs and the distal part of the upper limbs. So osteoporosis characterized by low body mass, low bone mass, microarchitectural, lead to disruption of the skeletal fragility and resulting in decreased bone strength and increase the risk of fracture. So the main cause of this, it's lead to fracture hip, fracture vertebra. Fracture hip, it's lead to sometime deformity, sometime deep vein thrombosis, sometime pulmonary embolism, and even death. That's why it's very important to diagnose early osteoporosis. It's called a silent disease. There is no symptom of this disease. Okay, the symptom occur after fracture. After fracture, the patient develops severe pain. For example, in the back, when there is fracture of the vertebra or compressed vertebra, lead to hump of the back. When do X-ray, we see there is a compressed fracture. Complication of fracture include pain and deformity. As I said, it's silent disease, but when there is fracture, it leads to pain, deformity, disability, and loss of height. Vertebral fracture is the most important clinical manifestation of osteoporosis, which occur in 2/3 of the patient, and usually it's asymptomatic. Hip fracture, it's increase with the age. For example, after 80, it's more than 15 or 5% they have fracture. But regarding the Colles fracture at the distal end of the forearm, it's common at the perimenstrual age. It's not like hip. So sometimes patient around female around 50 develop severe pain of the hand, and with X-ray we show that there is a fracture. The cause of osteoporosis, there is many causes of this. The most important cause, it's decrease the estrogen and the testosterone. When there is menopause, the testosterone decrease, so the bone become thinning. Okay, and regarding the female, when regarding the male, when the testosterone decrease, it's lead to thinning of the bone. But there is another cause of osteoporosis, like for example, chronic kidney disease, chronic liver disease like cirrhosis, increased incidence of osteoporosis, malabsorption syndrome like inflammatory bowel disease, celiac disease, all lead to osteoporosis. Other cause like endocrine cause is very important, because in patients with Cushing syndrome, patients with hyperthyroidism, patient with hyperparathyroidism, all this lead to secondary osteoporosis. And sometimes even drugs lead to osteoporosis. For example, PPI, this Nexium, and this tablet, all decrease the acidity of the stomach, lead to thinning of the bone. And sometimes thyroxine tablet also make the bone is thin. And heparin also increase the incidence of osteoporosis. Also, when there is decreased vitamin D and calcium, that's why it's more with absorption. How to diagnose? Usually, in my daily job, when I saw a patient more than 50, and sometimes I look to the bone is very thin in the X-ray, I sent for DEXA because there is no symptom. Even some patient, they told me that there is, doctor, I have maybe osteoporosis because I have pain, I have fatigue. It's not related to this. So most probably the osteoporosis is silent disease. How to diagnose this? We diagnose this very simple. We need first history, very short history about this, because you know there is no symptom. But I want to ask about if there is any family history, because family history is very important risk factor for osteoporosis. If there is history of a fracture, low trauma fracture, and her or his parents, this is also a risk factor for osteoporosis. The X-ray give a little idea about the osteoporosis. Only for me, in the patient with more than 80 years, sometimes I depend on the X-ray, but usually I depend on the test called DEXA study. DEXA study. This is the test. It's take about 20 minutes. It's less radiation than lumbosacral X-ray, and it gives idea about if there is any decreased bone mineral density of the pelvis or the vertebra, or sometime of the upper limbs. By this, we need to see. We depend on the scores. One called T-score and the other called Z-score. T-score, we diagnose the postmenopausal or the old age. We compared the potency of the bone of the same age with the adult bone. We see the difference. With this, we can decide the patient has osteoporosis or not. The normally T-score more than -1. Normally more than -1. When there is -1 to -2.5, this is called osteopenia, which means the bone start to be thin. After -2.5, which means that there is osteoporosis, there is a disease, there is decrease bone density, so it's need treatment. As I said, normally more than -1, between -1 to -2 osteopenia, less than -2.5 is osteoporosis. This regarding the postmenopausal. Premenopausal, we depend on the Z-score. Z-score, it's a comparison between the bone density of the patient and bone density of the same age of normal person. This is called Z-score. Z-score, if less than -3, this indicates that the patient has osteoporosis and need treatment. The problem of premenopausal, we need to think too much before starting the medicine for osteoporosis. That's why every patient after 30 years, please, need to take extra calcium, need to take vitamin D. Vitamin D is very important. When there is loss of vitamin D, there is less than 5 to 10 decrease of the bone density when there is low vitamin D. There's many patients who came to me, osteopenia, I gave him only calcium or vitamin D because I postponed, especially in premenopausal patient, I postponed the medicine for osteoporosis. Laboratory evaluation, usually I sent for vitamin D, I sent for calcium, and I searching for secondary cause of osteoporosis. Like I sent for renal and liver function, I sent for parathyroid hormone, I sent for total protein, and alkaline phosphatase is very important because sometimes this disease is occurring patient with multiple myeloma or patient take cytotoxic drugs. That's why sometimes we need to do some tests. Thyroid function test is very important because there is the most common secondary cause sometimes thyrotoxicosis. And if the patient came to me less than 50 years, I sent for testosterone to check the testosterone level because sometimes decrease the testosterone lead to thinning the bone, and this patient it's get benefit when takes testosterone. Which patient is recommended for DEXA study? Before the guideline, a female more than 65 or men more than 70. But nowadays, believe me, after menopause, I sent for osteoporosis. I show the patient has osteopenia or osteoporosis. So to me, every menopausal woman, I sent for DEXA study to check the bone density, especially if she has risk factor. Risk factor for osteoporosis, for example, in patient smoker, patient is alcoholic, if 2 drink per day increase the incidence of osteoporosis. And also if he has family history of osteoporosis. If he has family history of low trauma fracture, I sent for DEXA study. If the patient takes steroid, is very important. If patient take more than 7.5 milligram of steroid more than 3 months, is liable for osteopenia, osteoporosis, and decrease of vitamin D. So everyone which pay with steroid, I send for DEXA study. And patient with if he has history of rheumatoid, also I send for DEXA study. As I said, if patient is the DEXA study, the T-score is less than 2.5, which means that the patient has osteoporosis and need medication. But when the patient, when the level of T-score between -1 and -2.5, which means that the bone is osteopenia. So how to decide that the patient need treatment or not? There is a special web in the internet called FRAX. calculator, FRAX calculator. We can introduce or install the parameter of the patient, the age of the patient, the height, the weight, and if there is any risk factor, and there is some calculator. We see if the probability of the fracture, of the hip fracture, is more than 3% during 10 years, needs treatment, or if there is more than 20%, there is incidence of vertebral fracture, need treatment. This is the FRAX questionnaire. This is, there's UK, there's USA, even there's Middle East and UAE, Lebanon, and Jordan. There's we can put it the parameter of the patient, and there's a specific equation. We can enter the T-score, and we see if the patient has incidence of fracture of the hip or non-hip fracture, need treatment. We deal with the patient like the patient has -2.5. Okay, if the incidence is less than 3% or less than 20% for vertebral fracture, no need treatment. He need only vitamin D and calcium. Vitamin D and calcium is very important for the patient. So the management, now start with how to manage patient. The lifestyle measures is very important. Usually I counsel the patient regarding the exercise. It's very important for the patient because the exercise, especially weight-bearing exercise, like walking, brisk walking, jogging, sometimes is very, very good. And increase the bone mass, more than 50% increase the bone mass. And some patient, especially osteopenia, I encourage to do exercise. In weight-bearing exercise is very, very important. At least 3 to 5 per a week, more than half an hour. It's very important for him. And then calcium and vitamin D. Calcium, he need at least 1,200 milligram per day. And vitamin D, he need at least 800 international units. Usually, I encourage the patient to take good amount of fish. Milk is very important. And I encourage them to stop smoking. Is very important because more than 15 decrease the bone mass, and also avoid alcohol, and counseling on fall prevention, and also avoid any drugs that decrease the bone density. As I said, the calcium need 1,200 milligram. Some patient, I talk to them and I counsel them about the food because it's very important. If the patient take good amount of milk, yogurt, for example, fish daily or every other day, I told them to decrease the calcium. No need to take 2 tablets, take only 1 tablet in addition, because you know, a cup of milk, it give you at least 200 milligram of calcium, and if take soya milk, for example, more than 300. So it's better to avoid large amount of calcium tablet, because you know it's lead to calciuria and lead to sometimes renal stone. To me, I usually tell the patient to take 1 tablet only 600, but if some patient, they told me that purely vegetarian and they don't take any animal product, I told them to take 2 tablets of calcium. It's very important. And also vitamin D. Vitamin D. Usually before start treatment, we need to check the calcium and vitamin D. If vitamin D is low, need to give him either injection or large dose of vitamin D. Then after 3 months, we need maintenance of vitamin D. Candidate for therapy, as I told, if the patient postmenopausal, if the patient has fracture, low trauma fracture, And if the DEXA study, if the T-score is less than 2.5, is candidate for treatment. Usually, if severe osteoporosis, which means that the T-score is less than 3, in addition, fragility fracture. In patient with low bone mass, as I said, the T-score between -1 and -2.5. We need to use the FRAX calculator to check if the patient is on risk. As I said, 10-year probability of hip fracture more than 3% or greater, or 10-year probability of major osteoporotic related fracture of 20 years. This patient need medication. Usually this patient with risk factor, like smoker, like take steroid, he has history of rheumatoid, family history of osteoporosis. So we deal with this like a patient with osteoporosis or T-score more than -2.5. The first medication, it's called bisphosphonate. This is the first line management, initial therapy, because this is the first medicine we use it from 1990, which called bisphosphonate. We have alendronate or risitronate, or there is another once monthly tablet called apatronate. But the problem of this, it's not covered the hip fracture. Though to me, I am not use it. I use alendronate once a week. The problem of this medicine, if the patient has history of esophagitis or gastric problem, or he did bariatric surgery, or some old patient, they have many tablets. They have, for example, thyroxine, they have antihypertensive medication, antilipid. So there is many tablets on the patient. He told me that, doctor, please decrease the tablet, the number of tablets, because I take more tablet. That's why I prefer sometimes to use the injection. There is one injection called Prolia. It's every 6 months. There is another medicine, bisphosphonate, is called zoledronic acid aclasta. This is a very good medicine. It's covered the hip and the vertebral fracture. It's used once yearly, 5 milligram. And this is used as infusion in the emergency. It's take about half an hour. It's very good medicine. The problem of this medicine, there is flu-like symptoms. It's occur due to sometimes decreased calcium or decreased vitamin D. It's occur about 10% of the patient. The patient has severe fever and severe body ache. It's occur after the infusion. It's stay about 2 to 3 days, and usually I tell the patient that you have sometimes this side effect, and I give him some Panadol or non-steroidal if he developed this complication. You need to take it, and don't afraid. I tell the patient because he has severe pain. So sometimes the patient take 1 year this injection, and afraid that he will occur again this flu-like symptom. I reassure the patient that sometimes it's not occur, sometimes it's occur. It's not related to the medicine, it's idiosyncratic. But usually before starting this medicine, the bisphosphonate or any osteoporotic medication, usually I send for calcium, vitamin D, and renal function. And also to check the vitamin D is very important, because patients with low vitamin D, they have severe body pain. As I said, is not used in patients with esophageal disorder like scleroderma, like achalasia, like esophagitis, like the patient if they have gastric upset, and if patient with bariatric surgery. Pre-treatment evaluation, usually, as I said, we send for calcium, vitamin D, and renal function is very important. And usually, if the patient is first came to me, usually I discuss with them that if they have any dental trauma, any dental problem, like he want to implant the teeth or extraction of teeth, he need to finish this, and then after 2 months come to me to start medication. We can postpone the medication for 3 months. Why? Because sometimes there is a side effect. It lead to osteonecrosis of the jaw in patient if we doing some surgery of the teeth. This is very important. If the patient has highest risk factor for fracture, that way has family history of fracture, or the T-score is less than 3, we can use alendronate. Who are not, he can take the alendronate, bisphosphonate, or he has, as I said, that he has many tablets. We can start zoledronic acid, or we can change the medicine to another group, which called anti-resorptive medication. The bisphosphonate, there is many study nowadays, we can use it 5 to 10 years. For the zoledronic acid, we can use, there's many study now before 3 years, no more than, we can start more than 6 years. And usually when follow the patient regarding the treatment, every 2 years, we need to repeat the DEXA to see the T-score. If the T-score return less than 2.5, we can stop the medicine, we can stop the medicine, and we can make holiday. It's very good for the patient. If the patient has, for example, on bisphosphonate, but still the BMD or T-score is not recovered, not decrease, not increase, or sometimes decrease. So when there is decrease the T-score, we need to change the medicine, which means that the medicine is not working. We need to, the alternative for this for the bisphosphonate, we can use denosumab, teriparatide, abaloparatide, or romosozumab. For patient, if the patient came to me with T-score less than 3.5, which means that severe osteoporosis, or T-score less than minus 2.5 plus fragility fracture, we need to start from beginning anti-resorptive, anabolic drugs like teriparatide or abaloparatide. So this medication we use in patient with a fracture with T-score less than 2.5 or severe osteoporosis less than minus 3.5. We don't use the bisphosphonate, we use anabolic medication. The problem of this teriparatide, we use it by injection, subcutaneous, daily, for 1 to 2 years, not more than this. After 2 years, we need to start bisphosphonate, or need to start other type of anti-osteoporotic like denosumab or Prolia injection. The contraindication for this medication, this is the problem of this medication, sometimes increased incidence of osteosarcoma in rats, so we need to avoid. And also need to avoid in patient with primary or secondary hyperparathyroidism, need to check the calcium, need to check the urine, the calcium in the urine, need to exclude any case of hypercalcemia or hypercalcemia of malignancy, or patient have risk for malignancy or of family history of malignancy, need to avoid teriparatide. The risk of osteosarcoma, such as those with Paget disease, increase the risk of osteosarcoma. Patient with unexplained elevated alkaline phosphatase need to avoid teriparatide, or patient with history of malignancy like bone metastasis, history of prior radiation, no need to give him because increased incidence of malignancy, or patient with pre-existing malignancy, renal stone, persistent hypercalcemia, or renal insufficiency, need to avoid this medication. As I said, we suggest to use this medication not more than 2 years because of the risk of malignancy due to a lack of proven efficacy beyond 2 years. So usually we use 1 to 2 years, not more. And also it's very costly, this medication. For patients at high risk for subsequent fracture after discontinuing teriparatide, we suggest starting another anti-osteoporotic like bisphosphonate or Prolia, denosumab. For patients with at high risk of fracture, as I said, T-score is less than minus 2.5 with fragility fracture, or he has single vertebral fracture. We suggest to use denosumab. Denosumab, it's called Prolia, 60 milligram, one injection subcutaneous. It's painless, used every six months. And we can use it more, for example, 4 years for the patient. Is used in patient with renal impairment because the excretion is not through the renal. It's very good medication. And denosumab inhibit osteoclast formation, decrease bone resorption, and which increase the bone mineral density. The side effect of this medicine, sometimes drug reaction, and you need to do calcium before start this medication because it's not good to take it in patient with hypocalcemia. Denosumab is used for older patients who have difficulty with the dosing requirement of oral bisphosphonate, or who have markedly impaired renal function, and patients who are intolerant of unresponsive to other therapies. We can use denosumab. Should not be given in patients with pre-existing hypocalcemia. Usually I send the patient liver and renal function and calcium before starting this medication, but a patient with GFR more than 30, we can use this Prolia. Other indication for denosumab, men receiving androgen deprivation. For patients with prostatic carcinoma, we can use denosumab. Women undergoing breast cancer treatment, we can use this injection. Bone metastasis and treatment of hypercalcemia. As I said, patient with chronic renal disease, creatinine clearance less than 30, including patient receiving dialysis and or other conditions that predispose to hypocalcemia, malabsorption syndrome at high increase of hypocalcemia. That's why I need to check the calcium before starting. Following denosumab administration, then patient without these conditions. Sometime serious infection and skin reaction were reported, but is very rare. To me, I saw only one patient. He has a drug reaction after using this medication. I have more than maybe more than 500 or more patients with on Prolia. Raloxifene is selective estrogen receptor modulator. This medication is this medicine is weak in treatment of osteoporosis. It's used in patients with CA breast in women because it decreases the incidence of severe breast, inhibit the raloxifene inhibit the bone resorption and reduce the risk of vertebral fracture. So it's not prevent the hip fracture, usually choosing for osteoporosis when there is independent need for breast cancer prophylaxis. But the problem of this medicine increase the thromboembolic disease, increase the hot flashes, and less effect on the heart disease, and it's not lead to increased incidence of CA uterus like contraceptive pills or hormonal therapy. The new medicine is romosozumab. It's approved in 2019. Is very promising medicine. It's used in subcutaneous injection. It's very simple maneuver and painless injection, and it's there's many study about this medicine head-to-head with teriparatide and head-to-head with bisphosphonate. It shows that increase the bone mineral density, showing reduction in the vertebra, usually covered the vertebral and non-vertebral fractures. Is a monoclonal anti-sclerostin antibody. This sclerostin inhibit bone formation. So anti-sclerostin to prevent the osteoporosis, the osteoporotic bone. Patient with multiple, so it's used in patient with multiple fragility fracture instead of teriparatide. Patient with multiple fragility fracture, those at high risk for fracture who cannot tolerate any other osteoporotic medicine, or those who fail other osteoporosis therapy. This medication is it's very good. The side effect is not different from the other medication. Just need to avoid in patient with history of ischemic heart disease as myocardial infarction within 1 year. If there has history of this, we need to avoid. And nowadays, it's written in up to date 2020, and in the guideline, this is the medicine used for fragility fracture for severe osteoporosis and in patient or not responding to other medication. Very high risk uses very high risk fracture that as with severe or multiple vertebral fracture, it's covered the vertebra, covered the hip. Very high risk of fracture, such as those with severe osteoporosis. That's why it's less than -2.5, or a patient with multiple fracture. This injection once a month, and usually not use more than 12 years, because you know this is a very new medicine. This is clinical practice guideline up to date. This 2020. This considers the first line therapy in patient with multiple vertebral fracture or hip fracture and PMD in osteoporotic range, which means that less than 2.5 could be considered in the individual who fail the anti-resorptive treatment. I want to the side effect of this sometime drug reaction, or there is reported case of atypical fracture of the hip. This is not different from the other medicine of anti-osteoporotic, and it's not lead to increase the incidence of malignancy like other medication. The most important things should not be offered to women with prior history or increased risk for myocardial infarction or stroke. Reported cases of atypical femoral fracture, but it's not different from other medication. Treatment is limited for 1 year. I want to say a few words about osteonecrosis. This is the most important side effect, but it's very rare. It's occur 1 per 10,000. During my experience, I never seen this complication. This is very, very rare. The risk factor for this include cancer or anti-cancer therapy, invasive dental procedure, dental extraction, on dental implant, fully fitting denture, patient on steroid, smoking, or diabetes and pre-existing dental disease. When osteonecrosis occur, medication should be discontinued. Usually, this is the last slide. Usually, when the patient, before starting this medicine, I tell the patient, yeah, if you have any problem in your teeth, you need to finish it. Like, for example, extraction or dental implant. It's very important to finish it. And after 2 months, you need to come. I will start medicine. But if you start medicine, for example, after 4 years, you want to do this, we can stop the medicine 2 months. But you know, the bisphosphonate, it takes long time to excrete it from the body. That's why I tell the patient continue for the medication, but patient with the risk factor, I need to avoid these things. And this is very rare. Thanks a lot for your patience, and now we are ready for any question. Sorry if I am.
So thank you, Dr. Abdulameer. That was really a great insight in osteoporosis and treatment of osteoporosis. So being an orthopedic surgeon, I can really tell you it's a nightmare when we are treating fractures and joint replacement surgeries with osteoporosis, and it's a nightmare to put that implant. The bones are like butter. So I really appreciate, like, all these patients, and specifically the women post-menopausal age, when we are doing the joint replacements for them. And this osteoporosis treatment is really important before doing the surgery, and they have to continue after our replacements or any fixation of trauma also. So now the floor is open. If our attendees, they have any questions or queries, they can write it out, or there is an icon for hand raise on your screen. So we can unmute you and you can ask directly, and or if you can write it down, you want to write it down, we are there to help you out. And one more thing, after the end of the session, there will be a question answers sent on the screen. So everybody have to answer to those questions because it is a requirement. And after that, only the CME certificate will be sent to everybody through their email. So please don't forget to do that. So
Yes.
any questions on that?
Yes, I saw one question that how many years we can use a Prolia injection. Thanks for this very good question. Prolia, we can. There is now there is many study shows that we use Prolia more than 5 years. 5 years. We need to do DEXA study every 2 years. We will see if the T-score is still low. We need to continue. If not, if more than minus 2.5, we need to stop the medicine. We need to do some holiday for 1 or 2 years, then we will start. Because nowadays we diagnose the osteoporosis early. I have many patients that 50 years now, 50 years old, and patient, if we need to take it medication for sometimes 10 to 20 years. That's why I need every 4 years or 6 years, we need holiday, or 5 years, we need holiday from medication. When there is decrease the T-score, we need to stop the medicine and we need to repeat again. But during this period, we need to encourage them to take good vitamin D, to take good calcium, and to do exercise. Weight-bearing exercise is very important. Believe me, it increases the bone density.
So, Dr. Abdulameer, one basic question, like being an orthopedic surgeon, how do we decide like which DEXA to be done? Because whenever we are requesting for DEXA, it says whether you want to do for an appendicular skeleton or an axial skeleton. Means you want to do for the spine or hip or wrist. So how do we
Uh,
decide sending somebody for DEXA scan?
Yeah, I will do vertebra and hip. But you know, sometimes sometimes the patient old age, he has some osteophyte in the back, which this may make the reading is very difficult. So it's the hip is very important. And also sometimes the upper limbs, it's very important. But the most important things, vertebral and hip.
So if we say vertebra and hip, that means both like appendicular and axial skeleton. So not even one study. So both the studies should be done.
Yeah, and we
For
depend
hip
on
as
the
well as
lowest number of the T-score.
okay. So can you just tell us a little bit about what's the difference? Because when we read the DEXA report, it shows T score and Z score.
Yeah,
So what are we seeing in that? Whether we are seeing only just the T score or the Z score also?
yeah, this is very, very good question, because in post-menopausal women in the old age, in male, we depend on the T-score. If pre-menopausal or young man, for example, less than 50, we depend on the Z-score. Z-score, we measure the bone density of the patient according to the same age of the normal person. This is the Z score. This is in the young. But in the old age, we depend on the T score. T score, we depend on the difference between the bone mineral density between the patient and the young adult. So we depend on the old age, you depend on the T score. The premenopausal, you depend on the Z score.
Ah, okay. Uh, so there is one question from the audience. They want to know why it is common in Emirates and that vitamin D deficiency, in spite that we all know that UAE is supposed to be the hot city and everybody is exposed to so much of sun and heat. Why there is so much of vitamin D deficiency in Emirates?
The most the problem in UAE, you have good sun, but the problem of our duty usually more than 8 to 9 hours. Usually we we are in the office, and even our cars there is shadow, so we need to, we usually walk need to avoid the sun because it's very
So
it's very
basically the sun is there, it is free and we are not using it.
yeah, the problem. And usually I told the patient, if you need to expose to sun, we need early morning is very important, or late is very important, not more than 20 minutes. 20 minutes is enough to take good amount of vitamin D. But then sometime we are duty, for example, from 9 till 5. So we will not see the sun from the beginning till night.
One more question is there. They want to know that some patients they do come like if they're taking calcium regularly and they are scared of, as you said, renal stones. So in your experience, like is there some time limit a patient should continue on calcium or any particular form of calcium which doesn't cause calcium stones or renal stones, or can they
No,
continue for lifelong without being scared of renal stones?
it depend, as I said, it depends on the food. I tell the patient, if you take good amount of milk, if you take fish, yogurt, for example, ice cream, you need to avoid the calcium or take only one tablet. But patient sometimes fully vegetarian, he didn't take any animal product. I encourage them to take calcium, good amount, and you need to go for walking to prevent, and take good amount of water to prevent the stone. This is the only solution.
So
And
if
we need,
so if they're taking all this, so they don't need to be scared of forming renal stones.
very important. The calcium is very important. In the ages more than 35, you need to take good amount of calcium to preserve the bone.
There is one more question. How often we get our tests done to prevent osteoporosis? So how often a test is required? A DEXA scan or anything of that sort is required? How often does one get it done?
Yes. In postmenopausal women, we need to do DEXA scan, and in patient with if in an old age more than in male more than 65, we do bone scan. But nowadays, as I said, I saw many patients around 50 to 60, they have osteoporosis. So after 50, he need to do DEXA scan. And some patient, if smoker, patient with risk factor, for example, alcoholic, family history, he need to do after 50 DEXA scan, and not more than every 2 years. We need to do DEXA scan. But if patient, for example, an osteopenia, sometimes we use it after 1 year to see if they progress more. Because during the time of prenopausal, more than 15% decrease the bone density, this is very important for female especially.
Very good.
I want to reassure them that there is no risk for radiation.
For radiations.
The radiation is less than X-ray of lumbosacral.
So we'll just take one more question. They want to know, does the osteopenia is likely to develop to osteoporosis if not treated?
Yes. The osteopenia, sometimes patient has risk factor, need treatment like osteoporosis. Patient smoker, alcoholic, family history of osteoporosis, rheumatoid, patient on steroid, and there is osteopenia, he need medication. If not, need follow-up. At least sometime 1 to 2 years, we do DEXA study. During this period, he need to take good amount of calcium, good amount of calcium, of vitamin D is very important to prevent osteoporosis, because when there is decreased vitamin D, 10% of bone decreased bone density. So, and I encourage them to do exercise. Exercise, it increase the bone density. Very important weight-bearing exercise, like walking, jogging.
So coming to this weight-bearing exercise, somebody wants to know, like somebody who already has like an osteoporosis, severe osteoporosis or an osteoporotic collapse with painful bones, and we want to say that they should start on weight-bearing exercises. How is it practically like possible? Do they do that weight-bearing, or is it swimming and all those things are better, like cycling or swimming exercises, rather than going for a walk or jog?
Yeah, weight-bearing exercise, like even cycling, it's weight-bearing. Also, swimming is very good for this. And also even if he has fragility bone, the walking is good. The brisk walking is good. Not running, even the brisk walking or simple walking is very good.
Impact should be avoided. Impact sports, kind of like jogging and all, will lead to more impact and more fracture chances. Yeah, but brisk walking,
it's not practical for the patient.
Definitely. So I think we are at the end of our session now, and I really thank you, Dr. Abdulameer, for joining us and taking out your precious time on this Friday morning. And I thank all the attendees. And I hope this webinar, and this was our first webinar from the series of webinar by Canadian Specialist Hospital. And I really wish that we are all our Spider-Men of our society. Our UAE is recovering from coronavirus. So with great responsibilities and with great power will come great responsibilities. So do take care and don't forget to answer the questions, and the certificates will be emailed shortly. Thanks a lot. Thank you, everybody. Thank you.
Thanks.